We're live.
Okay, good morning. It is April 6th, and this is Senate Health and Welfare Committee. Thank you all for being here. Welcome to people who are out on YouTube. And just as a heads up for people who are looking in, we have a number of bills that have come to us from the House, and I know that there is interest in providing testimony on those bills. So if you have an interest in testifying, it would be very helpful for you to contact Nellie Marvel, our committee assistant. You can find her email address on the webpage, and just let her know that you're interested in testifying and which bill it is, and perhaps which section of the bill you're interested in testifying, if there is a specific section or two that you're interested in. That will help us as we go forward. The other area to let us know, and I know people are not hesitant about doing that, but our concerns regarding budgeting that we'll be talking about a little bit over the next several days. So if you have an interest in testifying on policy elements that are in the budget that came to us from the House, I think that's H 439. Am I right or wrong on that? Yeah, on H 439. Please let Nellie know that as well, so we can coordinate. It isn't easy for us, not being in the State House, to coordinate all the requests that we get. And I know a number of you make requests of your individual senators or people you know, but so it'd be helpful to send it in to Nellie. So that's all. That was an announcement. So good morning, committee. I thought that we'd spend a little bit of time this morning before the Department of Mental Health comes in, talking about some of the areas of the budget that we've heard about and that you're interested in, to formulate our message to appropriations. That's one. And then the other one is to look at the bills that have come to us from the House. And I'd be interested in your preferences, actually. I know there are some, and we've already started to line up testimony on some of them, but if you have a specific preference for a bill, what I'm going to ask is if you would be interested in taking the lead on coordinating who you'd like to have testify in on the bill, and what we should be looking at on the bill. So that's related to the House bills that we have. I also put some information on our webpage on the budget that I received from some of the child care advocates. So that's available to us today. So I am open to which one you'd like to take up first, but I think it might be easier to scoot through the bills that we have and then see, are there bills that you have a greater interest in of the bills that have come to us from the House? So I have the list that we have, and we are, FYI, I should have brought this up as well. There is a child protection advocate bill in House Human Services that has been given for forgiveness for crossover that we will be getting. And I am particularly interested in having that bill get to us as quickly as possible. I don't know the schedule right now. I haven't heard back from Rep. Pugh on that. But I think that bill might fit in with the discussion that we've been having on Kern Hatton and child abuse and neglect. So we'll add that bill to the list of what we've got in front of us.
Do you know the number of that bill, Ginny?
I don't have it on the top of off the tip of my tongue, but I know it's there, and we can look it up. I can look it up for you. It's right. It's in the House Human Services Committee.
Are we going to be
Senator Lyons, are we going to
Okay.
be doing more on Kern Hatton?
Yes, and that's important to understand. We are having a joint meeting with Judiciary. Judiciary is very interested in looking at the report, the non-relicensure investigation or the license investigation that went on by DCF, as we are. It's certainly our jurisdiction. And so we're setting that meeting up for next week. Right now, it looks like it could be on Friday next week, when we'd have DCF and perhaps Department of Public Safety folks in. So just a heads up on that one. So yes, we are. Senator Cummings.
Yeah. Senate Finance passed out, I believe the number is S-135. It was a committee bill on Friday.
Yes.
It's gone to rules. What it does is separate the individual and small group health insurance markets. Because of ARPA changes, it will save $17 million. It could cut that off of the cost of health insurance from the small group market, and it would not penalize or cause increases in the individual market.
Okay.
Yeah, so
Keep going.
anyway, it's sitting in rules. It's an S bill. I'm looking for an H bill to attach it to. I just emailed Representative Lippert, and I think I emailed him on Friday too. There is an S insurance housekeeping bill, but it's in Commerce, and health and welfare in the house, or healthcare in the House, has jurisdiction over health insurance. So the easiest way would be to have it attached. They are submitting their proposals, the insurance companies, for next year's rates as we speak. So time is of the essence on this one.
So, yes, I responded to a request from the Pro Tem's office.
Yeah, you had a couple.
Yeah, the one I think that does talk about rates. It's not insurance rates, but it's reimbursement rates.
Yeah, I saw that.
Home and community-based services. It's more of a study analysis. I think we could work on some language in that bill that would allow for that attachment.
Jen Carby took a quick look because she drafted this.
Okay.
She didn't think there was any, I mean, that would be
Okay.
hard, Jermaine. I don't think it'll get challenged because the healthcare advocate, the insurance companies, and the Chamber of Commerce all like this bill.
Well, we then very, very much love
Nobody doesn't like it.
it. We love it. Okay, so so will you keep us posted on that?
Yeah.
So you think that Jen thought that we couldn't modify H-153?
Well, we can. It just, if it got challenged, we'd probably lose.
Okay.
But the easiest thing would be if Representative Lippert, who had emailed me and wanted to know if we were doing this and is interested,
Right.
could talk to the Chair of Commerce and get it
bring the bill
attached to
out.
the insurance housekeeping bill, and we could get it done. I'm going to ask Becca to talk to the speaker and see if we can move that along, because even if it's an offset to an increase by increased pharmaceuticals, it'll reduce payments for small business, and if they ever needed it, this is a year they need it. So,
So can I ask a question just so I'm a little more informed about the bill? The ARPA changes that were made, are those then permanent changes, or is this a temporary?
No.
This is a temporary separation. I thought.
well, it's
I remember
for this year only, I believe.
Right.
There used to be a 400% of poverty cliff
Right.
So that some folk, I mean, people in the individual market are generally there because they really need the health insurance. They are generally expensive. But they are limited all in that market to 8.5% of their income for premiums. So we looked at this last year, the year before, to see if when the association plans came back in and then went back
Yep.
out at the federal level. And the study at that point said that if we separated them, because the question was, with the premium tax credits, was there still that necessity to keep them merged to protect the individual market? And the results was, if we separated them, there would be a 7% decrease in the small group and a 5% increase in the individual markets. But a lot of that was because of that 400% cliff. It now looks like the individual market will be held harmless, and the small group, which is healthier, could see a decrease, possibly offset by other increases, but they would be on their own.
So a quick question, and doing an analysis on this, is there, as going forward, is there any reasonable thought or benefit of continuing this?
Well, it's a federal
I
tax
know.
credit, yeah. So it is only for this coming year,
Yeah.
which is 22, which will force us next year if the feds extend it. But if they say, well, they're going to only be limited to 20% or 10% of their income, we need to be able to go back and reassess if they change this. So it's a 1 year with the intent of seeing what the feds do and then make the determination at that time.
Well, but it certainly would be, are there other states doing this?
Don't know.
Yeah, I mean, so certainly the data that's collected by NCSL or others would inform the federal government about keeping
I'm
this
trying
on
to
the
shut this off.
Senator Hardy is jumping out of her seat.
Yeah, she is.
So I just wanted to add to what Senator Cummings was saying, because I was just looking at my notes. The subsidies right now go to 400% of federal poverty level. The feds under ARPA increased the poverty level to 740% of the federal poverty level for subsidized health insurance premiums. And that would cover about 90% of the people in our individual market. And so the healthcare advocate brought this forward saying, most of the individuals would be covered if we split the two markets. The small group market would benefit because they right now basically subsidize the individual market. So without the necessity of the subsidies, because the feds are doing it, then the small group market would see potential savings. The estimate is still a little unclear because there's a lot of noise in the market, but the high end number that was mentioned is 17 million, but that's not a guarantee at all. And it is for 21 and 22, but for 21, it's too late for us to do anything because we're already in April. So this would be a provision that would affect 22. And they would have to make changes in the market, like Blue Cross Blue Shield and MVP would have to do things really quickly by like May. And that's why there's this urgency to get this through so that they can do what they need to do. There is a small cost, Senator Cummings. I don't know if you saw that email from Nolan, that Green Mountain Care Board would need a little bit of funding for their analysis, I can't, I'm blanking on what.
Gotta hire an actuary.
Yeah, the actuarial analysis. But I agree that the best way to get this through is with that miscellaneous insurance bill that's already in the House, if we can get them to attach it.
So I tell you what, that offers me great relief because I was not looking forward to having to pass a bill in a hurry. So,
Yeah, like
But-
tomorrow.
I got it. Well, I mean, look at if Commerce doesn't do what it probably should do, then we're going to have to step back and look at this. So, and I also wonder, not to go dive into what finance is doing, but obviously if Green Mountain Care Board is looking for money and this is an ARPA provision, seems like ARPA money. But
I wouldn't be surprised.
you know,
Yeah.
Yeah.
so for a couple $100,000, you can get an actuarial analysis maybe.
Right. And Ginny, to your, or Senator Lyons, sorry, to your question about other states, we are only one of 3 states that combines these 2 markets. So it's a really narrow thing
Yeah.
that most other states aren't doing. And it's because our markets are so super tiny.
Right. So maybe they should be giving consideration to the tiny states for a change, not just the small states, but the tiny states.
Tiny state
Yeah.
minimum.
Yeah.
We're already doing pretty well with our federal funding, I think, right now.
So far, so good.
Yeah.
Okay,
This
well,
is-
so
this has
that,
been, we've done, this is constant tension between these 2 groups.
yes,
And this is a chance to, at least for a year, to do something to help small business.
yeah, and our state is built on top of the small businesses, so it
Yeah.
would seem like a good thing to do. Yeah. Okay, I when I see it on the when I read it again, I may have other questions, but we'll hold that thought. So we do have some bills in committee, as long as we're talking about bills. And FYI, H-265 is the Office of the Child Advocate. Child and Family, I think they're changing the name, but that's currently in appropriations in the House. Because I think there's $100,000 associated with it to pay for the first year of the Office of Child Advocate. And I will share with you that when we met, oh gosh, it seems like a long time ago, pre-COVID, when we met with the Child Protection Oversight Committee, we heard significant testimony from the Office of Child Advocate in New Hampshire, as well as other states. As we start to see the issues associated with child abuse and neglect, thinking most specifically right now about Kern-Hatton, that having a legislative committee provide oversight. I mean, A, does that make sense? B, does it make sense for the department to have ongoing oversight when I think, we'll find out, but the support and funding for the services offered for child abuse and neglect may be wanting. And so the office in New Hampshire, for example, would take the lead on what they do, which I think is kind of interesting, is they go and they visit a place like Kern-Hatton and they spend time there and they are able to see, talk with the kids, talk with others to understand what's happening. So that's I think the immediate benefit for that office, or as we look at the bill, should we get it, when we get it, the immediate benefit would be to have some ongoing oversight where currently, and as we look at Kern-Hatton next week and rethink what's going on, when the state has no licensure to, then there is no ongoing oversight. The only oversight will be reporting abuse and neglect. So it'll be a reactive program. The Office of Child Family Advocate can be a proactive sort of prevention. So that's why I'm very excited about the bill, because it has that, offers that perspective. But so we'll just see. It's like the bill that Senator Cummings is waiting for. It's waiting for it. We're waiting for it, and we hope we get it. But as you're thinking about Kern-Hatton next week and child abuse and neglect, that think maybe take some ideas about the child advocate. Yes, ma'am. Senator Hardy.
Thank you, Senator Lyons. Your original question was the House bills and sort of what are,
Yeah, I'm going to go through the
was-
list. So
yeah, so I've been like
go ahead.
trying to come up with a priority list for myself and figuring out, so I'm looking at right now, the childcare bill is for me probably the most important in terms of its impact on the broad spectrum of Vermonters and
Uh-huh.
what we saw during the pandemic, or what we're still seeing during the pandemic and before. I also have a big interest in the Dr. Dinosaur
Mhm.
expansion bill. I think that's really important and could really have a big impact on the families, women and children who could benefit from that. The health equity bill as well, I think is really important for us to get out. The telehealth and the mental health bills, those both seem like they might, and I don't want to jinx them, but they might be easy to get out. Like they don't seem that controversial.
They're
Um,
so I was going to, as I was going through the list, I was going to agree with you on that. I think if let's go through the list and talk about each one, and then allow for each of us in the committee to have something to say about each one. So, excuse me. You brought up H-171, and we did hear some testimony on the child care bill last week. So that one has a prominence, I think, for a number of members of the legislature, but also out in the community. So I think H-171 is one that we will work on and get testimony in. If I think Senator Hardy, you've suggested someone you'd like to have testify on that bill. I think for us, we are going to have to look at the recommendations that have come to us from Allie Richards last week, or Sarah Kenny last week, who've been working on this for a long time. And then we do want to hear from others on that bill. So totally agree with you. H-171 is one we need to look at. The bill on, I'm trying to, that one will have some controversy about. There's no question as we move into appropriations. It has a huge appropriation in it. And yet it is a bill that, as you said, Senator Hardy, it's really very important. It's important for everybody, into the childcare industry, the families and businesses. So it's got broad interest. And I agree with you. H-104, that was the provider license reciprocity bill. That one probably, as you said, has less controversy. I think what we might do is try to put that one on our agenda at a time when we don't need to take a lot of testimony. I think that we'll hear some from folks. I haven't heard of anyone interested in testifying on that. If you know someone, send them in Nellie's direction. Then,
excuse me, Madam Chair, just
Mhm.
on that point, that bill and the mental health bill, the one person that Lauren Hibbert suggested we hear from on the telehealth bill was Commissioner Squirrel, who's going to be in later today.
right, she's not going to speak on the bill
Right,
today.
no, I know that,
Right.
but we could have her come in and talk to us about that one and also the miscellaneous mental health bill on the same day. Like,
Yes, I already have that scheduled. So you're right. That's a good idea. And then there are some other things that we want to ask about on mental health. We do want to understand what's happening with adolescents and the after school programs that are being scheduled, because there's a lot going on to reach out to kids during during the recovery period. So we'll I asked them to do all of that today, but they could not do that all today. So we'll have that sometime next week, I think. So that is H46. There was that one section that was crossed out, and I'm not sure whether people liked having that crossed out or not. So we're going to have to get some testimony on that little section. Then Dr. Dinosaur, that's a heavy lift. And it's a heavy lift because it implies expansion money. But I think for those of us who understand how many people this affects and who it affects, I think it's very important. So is there any reason not to do that one? No, okay. And then home and community-based service reimbursement. This is something that's been going on for a long time. I just read again a report from 2018. I think there was a little report from 2020, and the Green Mountain Care Board has been doing an analysis of some of the budgets for the DAs and SSAs that we asked for. So this one is a bill I think is overdue. So we need to look at it. I understand that there will be budgetary implications, maybe not right away, but going forward. But I still think in terms of policy, we should be looking at that. And I'll tell you why. If one of the goals for our healthcare reform or changes to increase affordability and accessibility for folks is to have access to substance use disorder and mental health treatments. So if we don't have these services in the state, we don't have those treatments. And that goes through the Medicare waiver that we'll be talking about tomorrow and following. So those are the bills. The equity bill, I think we all are. Senator Cummings, did you hear the testimony from Susanna Davis on H210?
Yes.
The equity bill?
Yeah.
Okay. Because that one seems like a bill that we can work on and improve our culture to reduce disparities and increase equity. And I did ask Susanna when she was in committee if having the chief prevention officer who resides in the governor's office, the agency of administration, if that would be a good addition to the bill. And she said yes. So that's helpful. Maybe we can bring in some of the prevention folks and see how the Prevention Council in the Department of Health might fold into this a little bit as well, because it is a cross-disciplinary council. So of those bills, am I missing anything, Senator Hardy? 153.
We got 171, the child care bill, 430, Dr. Dinosaur, 210, the health equity, 153, Medicaid reimbursement, 104, the telehealth, 46 is mental health, and then potentially 265 is the child advocate.
Those are the bills. Now, so what I would ask of you is if you have a special interest in one or more of those bills, I would let you take some time to sort out who you would like to have testify and let Nellie know, let me know, because as we're doing our agenda planning is going to get really tight. And So we'd like to have the testimony that will help move these bills along with appropriate changes, and your recommendations of who should testify without being overly redundant, because we can get a lot of people in who say this is great or this is not great, but we'd like to have folks come in who can make suggestions for improvement. So if you can do that. And so I would say let's the whole committee focus on 171, which is childcare. Let's do all of that together. Is Senator Cummings?
I guess, to me, the question with childcare, there's no question it's an economic necessity. There's no question it's good for families, it's good for kids.
Good.
The question is, how do we socialize the cost? Because we know how European countries socialize the cost.
Mhm.
But how do we do that? And until we figure out how to do that, the rest of it is still, organizing and who's in charge and who does what is the easy part. It's how do we pay for it?
You've got it. And I think that's one of the reasons it has come to us as a part of a plan, 5-year plan, but there are some investments for IT infrastructure that will be important and continue.
That's been around for a while.
That's been around. So
Yeah.
that one feels a little more comfortable, but then putting additional revenue in other areas, as you said, is this one time? How are we going to deal with this going forward? Completely understandable, which is why, and right now I'm looking at, I added it all up, but there's a lot of money in there. And it is in the budget as it came from the House. And we'll have to look at, I'll be talking with Senator Kitchell and trying to sort out what the thinking of appropriations is on this, but we also have to give our.
That's a one-time cost though, right?
Yeah.
Yeah, it's if we've already seeded that most parents can't afford childcare now. And the testimony I had at some public hearing was that the average childcare worker makes $29,000 a year.
If they're lucky.
That's average. So if we're going to raise that up to a living wage, how are we going to pay for it ongoing? It's not just the setup costs we can do. It's the ongoing subsidy that we've got to deal with.
And, I know that the conversation has been, everybody wants to use a payroll tax. Do we know that? Yes. And so the conversation has been.
I don't know that.
Oh, well, I mean, for there's an interest for paid family leave and.
Oh, yeah. Oh, no, everybody wants to tax the rich.
Yeah. So, but the businesses are very interested in having having childcare. Their employees need it. And so do they. So, but your question is exactly what we need to try to answer over the next how many years and how many more years. So part of the bill says we're going to improve the CCFAP so that people who can't afford childcare will have greater subsidies. And we're going to ensure that no one is paying more than 10% of their salary or their income for childcare. That would, if we just could do that. And so the question is, how do we do that? How do you ensure that?
Maybe we should hear from businesses that have set up childcare, because this was very in
Yes.
the early 2000s, 90s. National Life set one up. Central Vermont
Dealer.com, yeah.
Hospital set one up. I think St. Michael's just closed theirs last
Yes, they
year.
did. And dealer.com had one.
Yeah, and so,
UVM had one.
yeah,
There are a lot
Right.
of these places have closed because their other endeavors had to subsidize childcare. It sounds like private and public insurance subsidies, but the analogy.
no, we should know that,
Yeah.
why didn't these work? So we can
Do
not,
you have, if you have suggestions of who might be able to speak to that from National Life? I think I have folks I could get
it
from
was so long ago, I would have no idea.
St.
Yeah, that-
Michael's,
Got spun off.
the Edge, the fitness center in my area used to have childcare. I think, I'm not sure whether they still do. But it was just,
Casella Waste has it down here.
who does?
Down in Casella.
Casella has it?
Yeah.
Let's bring them in and ask them about it.
Yeah. I can check
Okay,
with that.
we can do that. I think Heather Shoulders is the contact for Casella. and We can have Nellie connect with Heather. Ruth, go ahead.
Yeah, I was just gonna say, in most parts of the state, we don't have businesses that are big enough to have their own childcare centers. I mean, it's really a Chittenden County, Washington County, maybe one or two in Rutland. I don't know. There was one in Middlebury, and it was, of course, Middlebury College. And now they're sort of partnering with a community organization and sort of doing it differently. And I think one of the reasons that businesses can't do it is so expensive. But I
Yeah,
also think we need to be realistic that, in most parts of the state, we do not have businesses large enough to have their own
Right.
childcare centers. And so,
well,
we
and
can't-
and it's so rural,
yeah, exactly. So
Well,
I guess I don't
when-
want to get too distracted by the possibility of doing that. We need to.
no,
Okay.
no, I think the question is, why didn't it work? We need to, so we don't, we don't go down the same path. We need to know what didn't work so we can reconstruct. The other thing we found is when we were looking, I think, at the unionizing of childcare
yes,
folks, is that the East Coast and the West Coast of this state are islands. In Chittenden County, 80-90% of the children were private pay, and they could make a go of it. You got North, you got Central with probably, maybe Rutland and and even Montpelier is struggling.
or the Bennington Brattleboro.
Yeah, but
Brattleboro.
if
And
you,
so-
if you,
Go ahead.
no, I'm saying if the bulk of your children are on subsidized pay, you cannot make a financial go of it.
No,
It's the same thing we're finding out with doctors. If the
And
bulk
Medicaid.
of your patients are on Medicaid, you can't survive financially. And that's an issue.
right. And it would,
My understanding with Casella was that they would subsidize the child care for their employees. I don't believe they had a center themselves, but they would
was it
subsidize their
incentive.
employees.
Okay.
Yeah.
Yeah, that's a different model.
Yeah,
Yeah.
it is, but it's a good model to look at.
I mean, in most parts of the state, the community-based and home-based providers are the ones that are the primary providers, and that's the primary kind of
Right,
model throughout most of the state.
right. And then we also have our parent-child centers, which we've been talking about. So there, maybe that's the model that becomes has greater subsidy. We don't know. So there is time for that planning process to go on, but you kind of have to have an idea of the choices you're making as you go along. So it is 11 o'clock. We accomplished about maybe a half, not quite, of what we were going to do, but we've invited Commissioner Squirrel and others in today to talk about some mental health issues. And Commissioner Squirrel, welcome.
Good
It's-
morning. Nice to see you all.
Yeah, it's good to see you. I'm going to pull up my agenda, which just disappeared. All right. So, our conversation this morning was more about H46 that we have in committee, and we'll be inviting you and other areas of interest that we'll be inviting you in to talk about another day. But today, we thank you all for being here to talk about the Middlesex facility and the plans for that. And if you could, and I see maybe everyone should introduce themselves from your shop, that would be great, from your area. So why don't we have you introduce your folks, and then we'll hear your testimony on the Middlesex Residential Recovery Facility.
Okay, great. Well, good morning. For the record, Sarah Squirrel, Commissioner of the Department of Mental Health, joined here by a few other members of the DMH team, as well as 2 national content experts who have been assisting the department on this overall project and other practice improvement efforts across the state. I will have Deputy Commissioner Morning Fox introduce himself, then Allison Richards, then Dr. LaBelle, and Dr. Huckshorn.
Good
Thank
morning.
you. Yeah, good morning, everyone. Thank you all for being here. I feel like we're all sitting around in the committee room, and we have an opportunity to have a robust discussion. We look forward to hearing what you have to say about the secure residential mental health facility.
Thank you for having us. And for the record, Morning Fox, Deputy Commissioner, Department of Mental Health.
Who's next?
I think it's me. Hi, I'm Allison Richards, Dr. Richards. I'm the medical director at the Vermont Psychiatric Care Hospital.
Okay. Kevin?
Good morning. My name is Dr. Kevin Huckshorn. I'm a national consultant on the use of EIPs and also on the implementation of trauma-informed care. I'm currently director of evidence-based practices for a international provider. And prior to that, I was a commissioner in Delaware, and then I ran the National Technical Assistance Center for State Mental Health Programming for SAMHSA and NASHBID for about 10 years.
Thank you. And Dr. LaBelle? Is it
Yes.
Dr. LaBelle?
Good morning, Senator Lyons and everyone. Thank you for the pleasure and opportunity to be here today. I'm Dr. Janice LaBelle. I'm a board certified psychologist working in a neighboring state and have a day job in a public mental health agency as the director of systems transformation. Also been working nationally and internationally on restraint and seclusion prevention, implementing trauma-informed care, and really affecting functional service systems changes to promote recovery-based treatment. So it's a pleasure to be here with you today. Thank you.
Well, thank you all. Thank you all for taking the time to be with us. We greatly appreciate it. And we are good listeners today. But we will have, I'm sure we'll have questions as we go through and as we hear about Middlesex. So Commissioner Squirrel, I'll turn it all over to you, and you can lead us through.
Great. Thank you. I'm going to go ahead and share my screen to walk us through the PowerPoint. We also sent a supplemental document, which is an overview of the future DMH recovery residents. So I would invite you all to take a look at that as well. Okay, can everyone see that?
So Commissioner, I think you have to decide how much you want to be interrupted or not during this. What our usual process is, if there are questions of understanding as you go through, then we ask those questions. We'll try not to get into too much discussion until after you've finished.
Great. Yeah, I think that's a great approach, Senator Lyons. We have a lot of content to share with you, and certainly can pause, throughout the presentation for some questions, but certainly want to make sure we hear from Dr. Richards and Dr. LaBelle and Dr. Huckshorn as well. So we'll just want to make sure we manage our time well. So I'm going to go ahead and get started. Some of the areas that we're hoping to cover with the committee today are just an overall history of the therapeutic community residents, the current Middlesex, looking at system of care needs, capacity analysis, and costs of care, talking about the future recovery residents and what we're hoping to accomplish by expanding and improving that. Dr. Richards will share some clinical perspectives. Deputy Commissioner Morningfox will walk through kind of a high-level overview of the current design of the future recovery residents. And then we will hear from Dr. LaBelle and Dr. Huckshorn as national content experts on the project. So I want to start with just a reminder about the history of the Middlesex Therapeutic Community Residence. It currently is located in the town of Middlesex, pretty much right on Route 2. Many of the committee members may have had the opportunity to tour the facility as it currently is. And just as a reminder, this facility was put into place post-Hurricane Irene as part of Act 79. So when Hurricane Irene impacted the state, we moved quickly to a decentralized level 1 state hospital system of care. It was also articulated in Act 79. And Act 79 explicitly called for the creation of a secure recovery residence facility. It was designed using FEMA money, 2 FEMA trailers that were put together. It was designed to be temporary. And 10 years have passed, and we have still not moved forward with a permanent secure recovery residence. During that time, I would also note that it was Act 79 that actually allowed us and provided the funding to build up our community system of care from a residential standpoint. That was when we created our network of intensive recovery residential facilities, many of our crisis programs, and other community programs across the state. And so certainly the current facility has outlived its lifespan and needs to be replaced. This is also critical in terms of our system of care. We do require having step-down transitional opportunities for individuals in the system who might not need hospital level of care anymore, but do still have intensive needs that can be provided in a secure setting. Also, just to note that for those individuals who are receiving care and treatment at the Middlesex Therapeutic Community Residence, they are on an involuntary legal status under the care and custody of the Commissioner of Mental Health, and they also have an additional order of non-hospitalization indicating by the court that this individual does require a secure setting. So just wanted to make sure that we were well steeped in the history of the current Middlesex. For those of you who have not seen the current residence, these are some photos of where it currently is. Very clear that it has outlived its lifespan. It was designed to be temporary. So the site itself has challenges in terms of poor drainage. It's challenging to maintain. Our partners at BGS have done a tremendous job. It doesn't have a permanent foundation. So you can imagine being in Vermont, that creates a whole host of issues for the facility itself. I think it's really important that we focus on the system of care needs. And certainly now more than ever, as we know with the pandemic, that having a strong, stable continuum of mental health services and treatment is absolutely critical. In order to provide the best care to Vermonters, we also need a robust continuum of step-down residential level of care. Increasing our step-down capacity in the system has been identified as a critical need. We have presented to this committee historically on our analysis of residential bed needs, where we see gaps in the system. And this is certainly an area and is a key component for those individuals who require 24/7 care and treatment. The replacement of the current Middlesex Therapeutic Community Residence and its expansion is a really critical and smart solution for us as a system as we try to really essentially improve flow in the system, which is our ability to manage individuals as they move through different stages of care and treatment. Certainly, we know that long wait times in our emergency departments are indicative of not having that flow in the system, meaning that folks are not moving through the system as we would like them to. I would also note that this a secure recovery residence serves a very particular cohort of individuals who are currently served in our level 1 beds and occupy a significant number of bed days. So when we look at the data, for example, in 2019, of the 5 residents who were referred to the Middlesex Therapeutic Community Residence, they had an average length of stay of 300 days in our hospital beds. So if someone is occupying that hospital bed for that longer period of time, it is taking away the opportunity for an individual who might be waiting in an emergency department to access that bed. So expanding this critical transitional step-down capacity will help us alleviate and improve that flow in the system. And certainly, of course, fundamentally, we want any individual who is ready to step down to a lower level of care to be able to do that on a timely basis. I also think it's important to note what we also value at the Department of Mental Health, and is certainly clearly articulated in our Vision 2030, is this balance and need for ensuring we have a strong and robust community mental health system of care. Vermont has long been a leader in this regard. This slide here really indicates the rate of community service utilization for Vermont compared to the rest of the United States. And you can see that Vermont is consistently has a higher rate of utilization of community-based services than the US in general. Also, when you look at our utilization of higher levels of care, such as inpatient, we have lower rates of utilization of inpatient care, thus indicating that our continued commitment to ensuring that we have a strong community-based system of care is a focus of the Department of Mental Health. It's a focus of our community providers, and something that we are continuing to be committed to. I also think this slide, really indicates that in terms of where are our budgeted dollars going in terms of community-based care and inpatient care. So what this chart here illustrates is the funding for mental health services across the state of Vermont sits in both the Department of Mental Health and DVHA. So DVHA, as our Medicaid payer, also pays for many of the community mental health and inpatient services. So what this slide illustrates is that in 2019, our total spend on mental health care, both community-based and inpatient, was about $315 million. 77% of that was used to support community-based programs, $244 million, and 23% of that was utilized to support our inpatient system. So again, I think this slide really articulates Vermont's continued commitment to ensure that our community-based programs and services are a top priority for the state. Folks on this committee also might be aware that Mental Health America recently put out a report in which Vermont was ranked #1 in terms of access to mental health care. So another indication, we always have more to do. We certainly are never going to pat ourselves on the back and say our work is done, but certainly I think demonstrates, again, Vermont's commitment to ensuring we have a strong continuum of care. I also want to note, and again, we're happy to come back to the committee as a follow-up to do a deeper dive on this. We're also really well positioned as a state right now. There's a lot of federal dollars flowing into the Department of Mental Health, all of which are intended to support our community mental health systems. So I just wanted to note, as we're looking at investing in these critical residences and facilities, we're also poised right now to really invest these federal dollars in our community mental health system. And so this just articulates the current tranches of funding that are coming into the Department of Mental Health that we have the ability to utilize over the next 1 to 3 years. And again, we have a lot more detail on this We did a recent presentation with House Healthcare where we really go through in detail some of these federal funding opportunities, but I thought it was important that the committee have some sense of this today.
So just as an addendum to that, it will be very helpful to have you come in and give us a deeper dive into some of the thinking that's going on around this money.
Great.
Yeah.
And again, just to underscore that these are funds that have to be deployed into the community. So that is where they will be utilized to strengthen and bolster our community systems.
And so, yes, and I won't ask the question now, but when you come in, it would be extremely helpful to know what the guardrails are and the guidelines are, because once we start investing in the community, then the question of continued operational expenses becomes an issue for us. So we'll look forward to that discussion.
Great. Thank you. Okay, so going back to just the system of care bed continuum, I think this slide is really important just to understand the continuum. So you can see in the top left here, we have our highest level, most restrictive level of care, which is our level 1 inpatient beds. So these are individuals who have been deemed to meet hospital level of care. They're experiencing an acute psychiatric crisis. And in addition to needing inpatient care, they've also been identified as having increased acuity and needs, whereas they are deemed level 1. So they require additional clinical supports in order to meet their psychiatric needs. We currently have 45 beds, level 1 beds. That's the Vermont Psychiatric Care Hospital, the Brattleboro Retreat, and Rutland Regional Medical Center. Then we have our general inpatient hospital beds. So again, we have 156 beds across the state. Again, individuals who meet hospital level of care, but have not been deemed level 1 receive care and treatment in these settings. Then we have our step-down secure recovery residents, so the current Middlesex program that we are proposing to replace and expand. Then we have specialized and enhanced funding. So these are individuals who are being served in the community, who also have acute needs, who have specialized funding that's attached to them to create individualized community programs. This is inclusive of some of the MyPad programs that kind of pair supported housing with on-site services and supports. We have our network of intensive recovery residences across the state. Again, residential level of care. They are staff secure, not physically secure. So a slightly different level of care for individuals where that is appropriate and clinically indicated. We have our mental health crisis beds across the state. Also our group homes, which are operated by our designated agencies. And we have transitional staffed housing, some of those programs who are offered, through partners like Pathways, and then independent living with services that are attached as well. So again, just to give you a sense of the continuum of care, certainly we want to ensure that for any individual, they're able to access the level of care that is most appropriate for them in the least restrictive setting. So I won't go through this in too much detail, but I do think it's important for committee members just to understand what level 1 means. And I think that's important because in the last 2 years, 100% of our referrals to the secure recovery residents, Middlesex, have been from our level 1 beds. So these are individuals who do have enhanced acuity. They have additional clinical needs, meaning that there are additional resources that are needed to support them safely, even in a hospital setting. So this is just a level 1 criteria, so you can get a sense of what we're kind of looking at clinically. And then that was also codified by Act 79 and has an additional fiscal piece attached to it that we need to pay reasonable actual costs for that care. But most importantly, it does just articulate that these are Vermonters with the highest levels of acuity across the state. And when they need to step down from those level 1 beds, it is absolutely critical that we have a secure setting with a respectful environment of care so that those individuals can also continue on their path to recovery. Also wanted to articulate the difference between inpatient level of care and a secure step-down level of care. So inpatient level of care is really, as I noted, for an individual who is in an acute phase of psychiatric crisis. Our inpatient beds are really designed for assessment and stabilization, what medications might be needed. These are individuals certainly who may be a danger to themselves or others because of what they are experiencing during that psychiatric crisis. It can involve court-ordered non-emergency medications and emergency and voluntary procedures. A secure step-down level of care, which is Middlesex, is very different than an inpatient unit. It is designed for a subacute population. So again, these are individuals who no longer need to be in the hospital, but they do need a safe and secure environment in order to step down to. There's also a much broader array of clinical and therapeutic programming that they have available to them. It's a longer length of stay, anywhere from 8 to 12 months. There's enhanced access to individual and group therapy, a lot of focus on skill building and social skills, what we refer to as daily living skills, cooking, food preparation, access to a kitchen, cleaning, house care, all of those pieces, as well as supported community engagement. So at the Secure Recovery Residence in Middlesex, individuals are able to go out in the community with their care providers to, maybe meet with. They might be working on transitioning to maybe a supported apartment setting. So it's an opportunity for them to have some time in the community, to practice social engagement and those skills so that when they are ready to transition to the community, they have those skills in place and are successful. So just wanted to articulate there are significant differences between hospital level of care and a step-down residential program. Also, it's important, this slide really overlays with that step-down continuum. So the highest level of care is also the most expensive. So this really articulates our level 1 most intensive level of care across VPCH, the Retreat, and Rutland Regional Medical Center. The column on the far right is the cost per day. So you can see Vermont Psychiatric Care Hospital, Rutland, and the Brattleboro Retreat, anywhere from $1,800 to $2,600 a day. Our non-level 1 inpatient units are just under $1,800 a day. The current Middlesex Secure Recovery Residence, our operating budget is around $3 million. It's about $1,200 a day. We did put some estimates in here in terms of the new Secure Recovery Residence, expanding that capacity, inclusive of additional staffing. Our initial estimates were just over $9 million. That comes in at about $1,500 a day. We have made some significant changes in some of the programming pieces. So that will actually adjust our staffing grids down a little bit. So we're still revising that number, but just to give you a sense again of the continuum of costs, our intensive recovery residential programs, our community-based programs such as the Soteria House, and that intensive supported housing. Again, just to give you a sense of the costs, the only thing I would also note to keep in mind, particularly for the new Secure Recovery Residence, is that we are able to utilize Medicaid funds for that. So when we talk about a $9 million operating budget, just to use that as an example, we're talking about a general fund need of, closer to $4 million. We also have monies that, obviously are already currently budgeted for the current Middlesex. So the general fund need for ongoing operating costs, we estimate between $2.5 and $2.7 million. But I just think it's important to remember that these are Medicaid funded programs as well. The data is really important in terms of how we make these decisions, how we look at system of care capacity. As I mentioned, 100% of the referrals to the Secure Recovery Residence are coming from our level 1 beds. We've served 53 individuals since its opening. The average length of stay is about 8 to 10 months. Just over 60% of the residents have stepped down to less restrictive settings or independent housing. And then our occupancy rates at the current Middlesex do run pretty close to 100% all the time, which is why we have those cohorts of individuals who are waiting in those level 1 beds, because our current 7-bed program is pretty much at capacity all the time. So the future recovery residence, which we are proposing, is to replace the current Middlesex with a state-of-the-art trauma-informed and responsive facility to expand the capacity from 7 beds to 16 beds that will address current need and unmet need. So when we talk about that demand, when we talk about at any given time, 8 to 10 individuals in level 1 beds who could step down, who cannot, because we don't have this capacity, is critical in terms of the data that we're looking at. It's also really critical that we can provide a high quality of care, that we can ensure the safety of residents. And these individuals also deserve a path to recovery, to step down from those more restrictive settings so that they can reintegrate back into the community. And again, these are individuals who are subacute. They are ready to step down. They do have increased treatment needs, and those treatment needs, can potentially pose a risk to public safety. These are individuals who at given times may have exceeded the capacity of our other community programs. So these are individuals where when I talked about that continuum of care, for some individuals, you can step down from an inpatient hospital bed right to supportive housing in the community, right to a staff secure recovery residence. For some individuals, that's just not the case. And our providers also know when to tell the Department of Mental Health when someone is exceeding their capacity. So these are also individuals who our community mental health partners are saying to us, we cannot admit this individual. This individual is beyond our capacity. And again, therefore, we feel a deep sense of responsibility to ensure that those individuals also have a safe environment in which they can transition to. And that really facilitates, success for them in the long term. They might need this step down secure setting while they can work on those skills and then can take that next step to an even less restrictive setting in the community. And again, we really think about this from an equity standpoint, that these are individuals who also deserve and require equity and access to high quality care and treatment. Again, I don't need to reiterate just the level of need in terms of the referrals coming from our level 1 beds. Replacing the current recovery residence and expanding its capacity, we think will have a material and significant impact on flow in the system. When we talked about those individuals and the number of bed days that they are occupying, our ability to move those individuals step down into this transitional level of care is critical. And again, it's the right thing to do for Vermonters. It would certainly be doing them a disservice to not have access to this level of care in the system. And also noting that collaboration and partnership are really key tenets to this work from the department's perspective. That is why we made the decision to not utilize emergency and voluntary procedures at this program. We had stakeholder input. It was very clear that the stakeholder input was to not utilize emergency and voluntary procedures at this residence. And we listened and we took that into account and we made that change. We will continue to engage with our peer and advocacy partners. We're really looking forward to having robust peer services and supports in this program as we move forward. And so again, that's just something that we really value as a department, and we'll continue to work with stakeholders around those areas. And again, I'll just wrap up with a little bit of a snapshot of the data again, just in terms of our success rate or our ability to transition individuals from Middlesex to lower levels of care in the community. We certainly know that the impact of the pandemic on escalating mental health needs The demand for high intensity services is not going to decrease in the short term, which is why this capacity is so critical. We talked about the long length of stays of this cohort of individuals in our level 1 beds. The improved environment of care in and of itself is going to be a significant advance forward from the current location. Again, we're averaging really high occupancy rates at the current program. And I noted our analysis of residential bed needs report that we did that indicated that at any given time, we have anywhere from 7 to 10 individuals who could transition to this level of care, but are unable to because we don't have the capacity. Also, as we look more long-term, Vision 2030 that the Department of Mental Health put forward really articulates a decreased reliance on inpatient capacity over the next decade. If we are to achieve that vision, we absolutely need to ensure that we have an adequate step-down system of care in place that can meet a variety of clinical needs for individuals. Also, members of this committee might be aware that the Center for Medicaid Services, CMS, is requiring the state of Vermont to look at the phase down of our IMDs, which are Institutes of Mental Disease, any inpatient facility that's over 16 beds. So again, in order for Vermont to achieve that, having this secure step-down capacity will be absolutely critical over the next decade. So I'm going to pause there. I'm going to turn it over to Dr. Richards. We think it's important also that the committee really understands who these individuals are. Dr. Richards has worked with many of these individuals who have transitioned to Middlesex. So I'm going to turn it over to Dr. Richards to provide some clinical perspective.
Thanks, Commissioner Squirrel and Senator Lyons and the committee for the opportunity to speak today. As the commissioner said, I have been working in Vermont since 2007 with many of these individuals. I'm a board certified child and adolescent psychiatrist and adult psychiatrist. And if there's 2 things I could share with you, it's to highlight sort of the progressive mental health system that Vermont feels very strongly in for Vermonters. And that ties into the equity that the commissioner's talking about for these individuals, these Vermonters that really need a place to step down out of the hospital and to be able to reintegrate into the community. And I want to be able to try to share some of their stories with you. I think the perspective is very important. So I'll tell you a little bit about, so I work at a level 1, VPCH is a level 1 facility, and we do have a lot of high complex needs individuals that come here. And again, they all have done something that has resulted in them being hospitalized involuntarily, at least at the level 1 facility. And then the goal is really to kind of be progressive and then work towards a step down. I have also worked at Middlesex and over 3-4 years been a psychiatrist there. And so I've seen both sides of this system of care. And so Gretchen is an individual. These are all fictitious, but they're made up of people that I've worked with. They're not here to tell you their story, but I'll share a little bit of the passion is that I want people to be able to move on with their lives when they're here. It's hospitalization. If anyone's ever been hospitalized, it's just not ever really a fun place to be when you don't have access to all of the things in the world. You're kind of following the medical system of care. And so I really feel passionate about getting people down to the next level of care. So Gretchen's 38-year-old woman. She's had a history of long hospitalizations and inpatient stays, including times where she's had court-ordered non-emergency involuntary medications. And her response to medications, sometimes they can help with symptoms, they can help with aggression, but they don't always treat the psychosis or the delusions. Sometimes those just don't go away. So she remains psychotic at baseline and has some delusional beliefs that just don't change. And during her hospitalization, she has these moments where she's dysregulated. She'll destroy property. She will assault other people, patients or staff. And these occur at a frequency of every 4 to 6 weeks. And other than these episodes, she remains psychotic, but she's behaviorally stable and doesn't require this level, the highest level of care. And due to this ongoing episodic nature where she destroys things, assaults people, the other community providers at the lower levels of the system of care, they don't feel that they can guarantee the safety of the staff or the other residents. And so Gretchen isn't able to discharge. She stays in the hospital because there isn't this other level where she can go. Randy is a 45-year-old man. So this is another individual that doesn't have access necessarily to be able to step down from the hospital. He's been charged with murder and has been found incompetent to stand trial due to his mental illness. He's refused medications, and due to his stable presentation in the hospital, court-ordered non-emergency involuntary medications have been denied by the courts, which is unusual, but it has happened before. So he remains delusional. He's psychiatrically not treated. The circumstances under which he was charged with murder kind of remain the same risk from a provider's perspective, that hasn't been treated. So he remains a risk. And due to public safety concerns and the history of extreme violence, the community providers in these other facilities that aren't locked or secured don't feel that they can safely treat him when he isn't treated. And so we can't really treat him in the hospital. There isn't any other place for him to go other than a recovery residence like Middlesex. And I'll do the next one. And then one more example is Greg. He's a 40-year-old man who's had a history of numerous psychiatric hospitalizations as well as placements at, we could say, every other level down the continuum. So he's been at all of the other group homes, the other residents, MyPad, Second Spring, and his lengths of stay at these group living situations have ranged from days to months. And what happens for Greg is he just destabilizes and ends up back in the hospital again. And when he's in the hospital, he needs non-emergency involuntary medications because he oftentimes will stop his medications in the community. And when he's been at the other residences, he's either eloped or assaulted other people. And so again, the community is saying they don't feel that they can safely meet his needs due to the elopements, the assaults. And so he's back in the hospital again, stabilizing. And the other agencies all say, like, we can't meet the need of Greg due to the ongoing risk of violence. And the challenge really is, Greg, he does well, he comes in, and he deserves also as a Vermonter to be able to step down out of the hospital. And as the commissioner described the program, anywhere up to 12 months, 4 months, 12 months, to be able to have that stable time in his life with a consistent team of providers, also going, cooking meals with staff. I'm working at Middlesex. We had a very holistic approach to meeting with the residents of the program on their terms, cooking together. We shared meals together. Community outings were important, if it's fishing or grocery shopping, to learn those life skills and the socialization and how to manage the times when he would go out to other facilities and just kind of not do well. It's a holding place, and then a place where he can move on from there. And I feel very passionately about this and the need for the new facility, and especially given the condition of the current facility, and then an expanded capacity so that we can have people in these level 1 beds just only as short as a time as they're needed. So I really appreciate you letting me speak. I don't think I have anything at this point.
Thank you. This is, I think, very enriching for us. Appreciate
Thank you,
clinical
Senator Meyer.
perspective. Yeah, thank you.
Thank you.
Thank you, Allison. So Deputy Commissioner Morning Fox will do a quick overview of just some of the current design renderings so you can get a sense of the environment of care that we're creating, as well as a sense of what some of the outside yard areas are. So Deputy Commissioner Fox, I'll turn it over to you.
Thank you. So what you see here in front of you, the following half dozen or so slides will show some artist renderings based on the architectural drawings and schematic drawings that we've been working with architect firms and the folks from BGS to put together. And this includes input from various stakeholders that we've received over the past probably 2 years now, as far as information regarding the look of the residence, as well as kind of the conceptual design and other areas internally. But part of the big piece is that we wanted to make sure that it looked like a residence, a large residence, but a residence nonetheless, and not a kind of brick cinder block kind of institutional feel. There's a lot of growing research around how living in a place that is more comfortable residential feel has a dramatic impact on one's mental health. And so what you see here, again, an artist rendering of what the front of the residence would look like, with kind of your classic Vermont porch as the main entryway. And that's where residents would come and go from. And new people being admitted would come through the front door. It's a residence, it's a home. People come through the front door, not through a sally port in the back, like at, maybe at a hospital or something of that sort. And so, there's a place for, drop off and pickup, as well as, you'll, again, just trying to make it have that feel of a residence. Okay. So you can see this is a site design of the entire kind of area. And down at the bottom where you see the words drop off, that's really what we were just looking at. The image was looking at that area. That's the front of the residence. It's a little tough to tell in this image where the fencing is for the yard, but it's basically in the back. You can see where it says raised garden and gazebo. To the left of that, oh, there it is, even better. Thank you. I forgot we had that slide. So the areas that the commissioner is showing now, you have one area of a yard here and one area of the yard on the other side. A little over 6,500 square feet in one and just over 4,000 square feet in the other, giving us a total of just shy of 11,000 square feet. And those yards butt up against the other building, which is the existing gymnasium that we will be leaving on site, which will provide other space for activities, both in good weather as well as in inclement and our long winters, so that people can still have kind of that outdoor activity and exercise in a safe, temperature controlled environment. But there will be a lot of places for people to sit, to congregate, to have meals outside or have groups outside, one-on-one conversations. There will be walking paths, raised garden beds, things of that sort. So there's really quite a lot of space to be provided with easy access from multiple locations from within the residence. This is just an example of one of the larger rooms, gathering rooms in the residence. This is what we were referring to as a multi-purpose room. It can be used for everything from watching elections to sporting events to having groups and group process, as well as even smaller things where maybe just 2 or 3 folks are using it at a time, maybe to have a separate meal in a quieter place or something else. But you'll notice in this and in other pictures, lots of large windows that are functional, that are able to be opened to have fresh air come in, getting in a lot of natural sunlight, and similar with the kind of natural, softer tone colors. Again, going back to research and best practices in design of residential placements for folks with in recovery from mental health services, is the access to bringing the outside in. That having that natural sense really supports one's mental health and has a significant impact on their progress during their recovery as well. And this is actually the same room, but just from a different angle. But just what I wanted to point out in this image is you'll see the round window on the left is actually faces where the nursing area is in the residence, so that it allows nursing to be able to see in through that window for some sightline visibility. The doors that go into the room, as you'll see at the end, are also glass or plexiglass, but that you can see through as well. So there's numerous lines of sight, but also, again, to help with keeping it a bright and airy type space. And if you go out that, you come into, no, it's okay. We go into one of the other rooms, a living room area, which is right near the entrance, actually, that is set up kind of as a pseudo library space, but also provides separate spacing. Again, the large windows, the windows in the hallways. Again, so even if it's a smaller space, having all the windows gives it a much more expansive feel to it, the sense of space, but also it allows for good viewing for the staff. Because one thing is we're designing the residence is also being mindful of the cost of staff and not wanting to have extra staff needed because of lines of sight issues and concerns around that. And so really we're intentional about helping to create the ability to see into various areas for the staff as they're working there as well. This is one of the main gathering areas, central hubs of the home. Like in many homes, the kitchen dining area is kind of a central gathering area. This will have the capacity to have the 16 residents eating together. Tables can be separated so that they're not as together. Folks can sit at the breakfast nook as well if they're looking for kind of a smaller conversation or getting away from some of the hubbub. What you also see on the left side there is the residence kitchen, and it's a fully functioning kitchen that they will be able to use on their own with staff to develop skills. And again, the main goal is to help folks develop those skills so that they can move on from this residence to more independent living. And some of that work is learning those skills to live independently, part of which is building grocery budgets, going shopping, and then putting meals together. There is a commercial kitchen that is in the back of the building. We'll have staff that provide meals three times a day, all meals and snacks for the residents. So this is in addition to their own meals and such like that. You'll see in various places within the hallways, again, separate small little congregating places where an individual can sit by themselves and or sit with maybe one or two other individuals so that they can have either some quiet space that's outside of their room, maybe wanting to be out in the milieu, but not necessarily in a large multi-purpose room or living room area, but then having these types of sitting alcoves where they can have some quiet space or maybe one-on-one time with another resident, a peer counselor, their caseworker, things of that sort. And then this is a rendering of one of the bedrooms. Each bedroom has its own bathroom, so there's no shared bathrooms, no having to walk down a hallway to go to the restroom or anything of that sort. We also were intentional in not wanting to place in the residence your typical twin bed type thing. Most of us as adults don't sleep in twin beds. They're relatively small and narrow, unless you're as small as I am. Most people do not fit comfortably on a twin bed, and so we made sure that all of the beds are full size, and all the built-in cabinetry for people's own personal belongings. And the idea here really is that, for the next foreseeable future, several months, several weeks to months to up to maybe a year, this is their home. And so that they have the ability to decorate it as they would like, and really to make it their own as as they see fit. But again, windows to the outside that are openable and operable by the resident, and things of that sort. So, and everything is designed with also kind of the psychiatric perspective in mind, and ligature proof, ligature resistant materials and designs as well. And then finally, just wanted to touch base on the fact that we really are trying to imbue trauma-informed approach throughout not only the design of the residence, but also in the operation of the residence. Treatment plans and things of that sort are highly important to have the resident be involved and have their voice, that it's resident centered and resident led, and how their treatment will evolve, how their recovery there will be involved, that they really have a sense of being empowered to say, here's what I want my treatment, here's how I want my recovery to look like. And so we really envision that the residents would really take an active and leadership role in the design and direction of their treatment plans, as well as having peer advocates to be there to support them, to help them to learn how to have that active voice and to advocate for their own needs, as well as having peer counselors as part of the treatment team to really help support them and support their recovery through this process.
Great. Thank you, Fox. And now we thought it was important to hear from Dr. Kevin Huckshorn and Dr. Janice LaBelle. They've been critical partners for us in the state in terms of implementing 6 core strategies to reduce seclusion and restraint. And they've been critical in advising us on this project. So I'll turn it over to Dr. Huckshorn and Dr. LaBelle.
Thank you, Commissioner. This is Dr. Kevin Huckshorn again, and thank you, honorable legislators and the rest of the state staff for giving us a few minutes just to weigh in. Both myself and my colleague have worked with the state of Vermont probably since about 2005 ourselves in helping to reduce the use of EIPs and implement trauma-informed care. So it's an honor to be back. I first want to just congratulate the state of Vermont. You guys really should be very proud that your system of behavioral health care. I have worked in probably all but 3 or 4 states over the last 20 years, and you really have demonstrated your incredible commitment to evidence-based trauma-informed practices throughout your entire system of care. Your access to care is excellent. And you have really partnered with your very powerful advocacy groups and have relationships that may be strained at times, but that's normal with advocacy and state staff and trying to meet everybody's needs. So I guess I'm just going to make a couple comments. The first is that all states have a top priority, if not the highest priority, to meet the needs and services required by people with serious, complex mental health disorders. And this is the group of people we're talking about today. I personally am a very strong believer in the Americans with Disabilities Act and the Olmstead decision, and have helped a number of states implement those principles, which basically say people can live in communities and should be able to live in communities, in their own apartments, in their own homes, with a natural social support system. However, what we're talking about here in terms of the Middlesex facility are the small group of people that all states grapple with and struggle with. These are folks who may or may not, and certainly may not right now, but are very similar or meet the criteria that Dr. Richards talked about. These are your fire setters, your people with sometimes inappropriate sexual behaviors, serious felonies, people that have patterns and habits of self-harming, people that have very poor self-care skills, who in the old days probably would have gone into a nursing home, people with right now not controlled substance use disorders, and people like Gretchen that are treatment resistant. No matter what we know and try, we still haven't figured out that remedy. These are the people that in the old days were forgotten. These are people that were forgotten in state hospitals and either lived there for decades or the rest of their lives. And even though, yes, some of them could be cared for in the community, the cost of care would be over your level 1 expense costs. It would be probably close to $1 million a year for one individual. And that's just not efficient or a good use of dollars nowadays. So basically, while this group of folks are very small, they also have very specific needs that we now know in 2021 how to treat. And what we're talking about here is psychiatric rehabilitation. It was identified through a lot of research and studies over the last 20 years that a lot of folks who have these complex mental illnesses can indeed eventually live in the community. But the way they can do that is if they get the type of services that take longer and are different than the type of services you get in level 1 or crisis stabilization beds. Those are skills, as the commissioner had noted in the PowerPoint, that include managing your own recovery plan, writing your own RAP plan, which is an evidence-based practice, shopping, money management, cooking, taking transportation, public transportation, how to use electronics, how to do basic housekeeping. These and most important are the socialization issues that people need to learn by living with other people before they try and live on their own. Those are skills that are critical, and currently working with the US DOJ on another project. One of the emerging concerns is the loneliness experienced by people who haven't built up those socialization skills and get put into apartments all by themselves, who then have no one. And we need to do a lot more work on that. So last, I think that the debate here in Vermont, if you would be so, if you would give me that opportunity to say, the debate should not be between community services versus inpatient residential services. The debate should be about how to create an even better system of care than the one that you all are leading the way on in the country. And how to do that. And part of that is going to be plugging this hole, this gap for these people that really need these services and who waited for some time, and who your state staff have done so much work to prepare the road going forward for them. So I'll step down and turn it over to my colleague, but thank you for the pleasure of talking to you today.
Thank you, Dr. Hochschorn, and thank you, Senator Lyons and fellow committee members. This is Dr. Janice LaBelle, and it's very hard to follow such eloquent speakers, and I'm sure you've got questions. And at the risk of being redundant, I'll just sum it up by saying, as a neighbor working in state government, please believe me when I tell you that Vermont has enjoyed such a reputation outside of your state that you may not be as well aware of as we who are not Vermont residents are, about how impressive your service system is. And that doesn't just happen. That happens because of stellar leaders, and you've just heard them today. So I just want to underscore a few points that we in public mental health are all preparing for the pandemic-related tsunami of mental health need that is headed our way. And we have to have a system of care that flows, and it can only flow unless you've got good link pins like this, recovery residents in place to be able to help move people through the system, and not just move them through, but as Dr. Hochschorn and others identified, having them prepared to live in the community opportunity, because ultimately that's the litmus test of the power of the work that's being done. Not how well they do in residence, not how well they do in a hospital. They should do well there. They're getting all the bells and whistles and props. But the test of our work is how they succeed once they leave. And every ingredient that's needed to be successful is embedded in the design that's before you today. It's consistent with evidence-based practice. Trauma-informed, trauma-responsive care is much more efficient and effective and cost beneficial when it's properly implemented. And this design delivers that to you by the physical plant, the views of nature, which are absolutely calming and underscored by evidence, the skills-oriented approach. So what you have before you is prudent, it's pragmatic, it's reasonable, and it's necessary. So I thank you for these few minutes, and I will stop and pause here because I'm sure you've got wonderful questions. Thank you again.
Listen, I can't thank you all enough. This is exceptional and extremely helpful to inform us as to where the current thinking is. And I guess we do have a lot of questions, but unfortunately, we're at a real hard stop. So what I'm going to suggest is, Commissioner, when we schedule you in, that we have some time for questions and discussion on this, as well as some of the other issues that we were going to talk about, and including adolescent mental health needs as a result of the pandemic. I know those are ongoing issues for us. And then the funding, as we do see, Dr. LaBelle, I was happy to hear you mention, not happy about it at all, but the tsunami that's going to be coming at us, mental health tsunami related to the pandemic. So, but I mean, I do have questions, just at the broadest level. I think it will be important for the committee to understand the places where emergency and voluntary treatment is utilized, and then where it is not utilized. I know that's been an ongoing question and discussion, but I think just to help us understand where you're thinking on that, and that you have made some decisions as a result of talking with folks. So I'd be happy to hear about that. And then the other area is in the area of programming. Obviously, what's going on in this new facility is going to be critically important for the improvement and the recovery for the folks who are there. So, and I know we've had the programming discussion in the past, but what the thinking is there, because that's where our committee really can support the good work that's going on. And then also workforce, and how we're going to have sufficient workforce to carry out the work that's here. I mean, you talked about peer support, but it's broader than that and greater than that. And then as I'm very acutely aware of the need for some spacing for people when they work in these environments, needing some time, their own time, downtime. So how that's being evaluated from a workforce perspective. So those are some of the questions we might want to explore going forward. But I cannot tell you enough how very I was going to say happy, but how pleased, but how informative all of this has been, and the giant leaps forward from where we might have been last year at this time. So thank you all. Committee, any final thoughts? Dr. Huckshorn, you had your hand up. Were you going to comment? Okay, that's good. Just goodbye. I know we're over time a little bit. Senator Hardy.
I just wanted to, well, first of all, thank you all for testimony and explanation of this project. This is in our capital budget right now, and reviewed by our institutions committees. I just wanted to make sure that anybody who's listening from the outside, this is not related to a bill we're working on specifically, but related to our capital budget, which is being taken care of by another committee. It's obviously important that we know this information, but
Well, it is in our committee. What is in our committee, obviously, are all of the policy decisions that are being made. So when we start talking about emergency and voluntary procedures, that is our committee. And so that.
No, I understand that,
yeah.
but the facility itself, that's what I wanted to make clear. It's not.
Yeah, no, well, what I was going to say is, yes, you're right, but also the treatment modality and the way patients are handled informs the facility. So that has to be hand in glove. I know you get that. We understand, but so we'll come back to this another day, and we'll try to stay. I have been staying in touch with our institutions committees and other committees who have been hearing the testimony and asking questions. But we'll also want to put our stamp on this as well.
Of course.
So.
Great. Well, thank you all for your time this afternoon now, and we'll look forward to coming back, responding to some of those questions and also digging into some of those other topic areas that I know, Senator Lyons, you were interested in having us address.
Terrific. Okay.
Wonderful.
Thank you. Thank you, committee. We just used up some of our early endings. So apologize.